So you'll be here.
Joining our webinar session for today. So today we'll be looking at triage and management of COVID from the outpatient to the ICU. Right now, we are in the event where Kenyans, our borders, we've opened them up. People from Nairobi, Mombasa, Mandera can actually travel freely, and we are expecting a surge of cases throughout all the counties. So we'll be hearing the Seattle experience as how they've done it from triage and management of COVID. Now from the outpatient triage to the wards to ICU, that's what they'll be doing. They'll be presenting to us. My name is Dr. Nancy Ngumba from Kenyatta National Hospital. Our presenters today are Yilin Zhang, Mark Mayo, Nick Johnson, and Janelle Stewart. So I'll hand it over to them to introduce themselves and start the session.
Hi, my name is Yilin Zhang. Can everyone hear me?
Yes, we can hear you.
Oh, wonderful. Hi, my name is Yilin. I'm one of the hospitalists at the University of Washington Medical Center in Seattle, Washington.
And hi, I'm Mark Mayo. I'm also a hospitalist at the University of Washington in Seattle.
So we'll be giving a presentation today on the triage and management of COVID-19 from the outpatient to ICU. And then we'll open it up to a panel discussion, and Doctors Nick Johnson, who is dual emergency medicine and ICU trained, and Dr. Janelle Stewart, who is infectious disease trained and does a lot of work here in Kenya, will be joining us for that panel discussion. All right, let's go ahead and get started. So we have no disclosures. A brief outline of the things we'll touch on today. We will briefly review the spectrum of COVID-19 disease and risk factors for severe disease. We'll talk about our outpatient monitoring program, our admission criteria, infection prevention and the creation of our COVID-19 hospital units, complications of COVID-19 infection in hospitalized patients, and then we'll briefly review our inpatient treatment protocols for patients with moderate, severe, and critical disease. So we'll introduce you to Mr. A. He's a 23-year-old healthy man who presents to the A&E with 24 hours of fever to 40 degrees Celsius at home, cough, and shortness of breath. He has no chest pain or sputum production. He also reports watery diarrhea for the past 2 days. He works from home and has had no sick contacts, but recently traveled out of state. He has no past medical history and no medications. He doesn't smoke and drinks 1 to 2 drinks per month. So let's talk about some of the ways that COVID-19 can present. Overwhelmingly, the most common symptom is fever, present in up to 99% of all patients, though less than 50% of patients may have fever on clinical presentation. Cough and dyspnea are also very common, present in over 2/3 of patients. And this classic triad of fever, cough, and dyspnea are actually only present in a minority of patients. Fatigue, myalgias, arthralgias, which you might associate with an acute viral syndrome, are also very common. And increasingly, we're seeing reports of GI symptoms such as anorexia, nausea, and diarrhea. URI symptoms, upper respiratory symptoms, are less common, such as headache, rhinorrhea, or sore throat, though still can be seen. In terms of the spectrum of disease, we know that the vast majority of patients with COVID-19 will have mild or moderate disease, so either no pneumonia or very mild pneumonia. About 14% of patients will have severe disease requiring hospitalization. These patients will have dyspnea, tachypnea, hypoxemia, and pretty significant lung infiltrates. And then a small percentage of patients will have critical disease, which is defined by respiratory and multi-organ failure. Some of the well-known risk factors for severe disease and death include older age. This is a plot of case fatality rate by age that came out of China. And what you can see is that the case fatality rate increases with each decade of life. In fact, in this cohort of over 44,000 patients, over 80% of deaths occurred in those older than 60 years old. And we also know that chronic comorbidities are associated with severe disease and death, with the most notable being hypertension, cardiovascular disease, diabetes, chronic lung disease, cancer, and obesity.
So continuing with Mr. A's case, at the time of his initial presentation, his physical exam is notable for a fever to 40.2 degrees. He has a heart rate in the 110s, a normal blood pressure, tachypnea with a respiratory rate of 24, and a saturation of 92 to 99% on room air. His cardiopulmonary exam is normal. His abdomen is soft and non-tender. Some of his initial laboratory studies are shown here. His UECs are below and essentially unremarkable. His liver studies are initially notable for a mild elevation in his transaminases, but otherwise normal. And his FHG shows a normal total leukocyte count, but with relative lymphopenia, with an absolute lymphocyte count of 750 cells per microliter, with a normal H&H and a normal platelet count. His initial chest radiograph is shown here and is read by our radiologist as being without an infiltrate. And at the time of his initial presentation, he also has a rapid influenza and RSV nasopharyngeal PCR swab that's sent that results negative. Now we'll touch briefly on viral testing, how our process changed at our institution over time, beginning with initially when we had more limited testing capacity and who we chose to test. So initially we considered testing those who were at-risk populations. So as we've already sort of identified, those of older age or age greater than 60, those with the presence of medical comorbidities, immunodeficiency, if someone had a contact with a known confirmed case of COVID-19, if they were a frontline healthcare worker, or if people had a communal living situation or no stable housing and were going to be at an increased risk of transmission and infection to others. And additionally, of course, if patients presented with an acute respiratory syndrome, they would undergo testing. And then over time, as we had more testing capacity, we ended up actually screening all admitted patients to the hospital and then performed pre-procedure testing on anyone before they went a procedure within 72 hours. And then as time went on and we saw some patients were actually presenting with symptoms other than those of an acute respiratory syndrome, for example, GI symptoms, or with anosmia or ageusia, those patients would also be tested and considered symptomatic at the time of testing. So in Mr. A's case, it seems like he has mild disease at this time of his initial presentation without any evidence of lower respiratory tract disease. And then when we considered patients at the time of their evaluation and tried to determine their disposition, they fell into one of these four categories in terms of disease severity. Mild disease, as I said, with no lower respiratory tract disease, moderate disease being those patients with evidence of lower respiratory tract disease who often required admission, and then severe and critical disease where the disposition could be a little bit harder to figure out depending on the severity of illness. Now, for Mr. A, at the time of his initial presentation with mild disease without any evidence of lower respiratory tract disease, we did a little bit of further risk stratification to determine whether he was at low risk or at high risk in order to help decide whether or not to admit him. Let's talk about that a little bit more. So for patients when they presented, they were deemed to be at low risk if they did not have any of these risk factors present. So again, things that we've seen, older age, the presence of medical comorbidities, immunodeficiency, or concerning things like altered mental status or signs of pneumonia. So if patients did not have risk factors, the next question we asked ourselves in order to determine the disposition from the A&E was whether or not the patient had the ability to safely self-isolate. If the answer to that question was yes, if they were to leave the hospital, then the patient would be discharged home or to their place of residence, given instructions on how to self-isolate safely, and then they would await their COVID-19 PCR results from home. If that test resulted positive, then those patients would join our outpatient monitoring program, which we'll discuss in a little bit more detail. And then stepping back, if patients were not able to safely self-isolate clearly outside of the hospital, we actually eventually had some publicly funded housing for patients with positive tests to be able to isolate. So we actually had a hotel where people without stable housing could stay if they were COVID positive to sort of wait out their symptoms. And there were some shelters available over time as well. And the other branching point, if a patient was not able to self-isolate despite being clinically ready for discharge from the A&E, we eventually actually were able to keep some patients in a special waiting area in the ED, as we call it, or A&E, until their COVID-19 PCR test resulted and we were able to make that determination. Now, for patients who are at increased risk, the decision to admit could become a little bit more complicated. Of course, if they had persistently altered or abnormal vital signs or concerning exam features, it was a relatively easy decision to admit the patient to the hospital. However, some other things that we took into consideration were these risk factors, which you'll see again and again. So if patients were older, if they had other medical comorbidities or any of these other features, those could weigh into our decision with regards of whether to admit the patient or not. And then as these laboratory features emerged, as more data came out with laboratory features associated with non-survivorship or severity of illness, we also would factor in some of these numbers into our decision with regards to whether to admit the patient or not. So things like an elevated D-dimer, elevated inflammatory markers, severe lymphopenia, or the presence of end organ dysfunction. Now, while risk factors, either labs or based on history, would not independently lead to admission, they were things that we still, I think, are somewhat grappling with in terms of what to do with those numbers and factoring them into the whole clinical picture when making a decision to admit.
All right, let's return to Mr. A. So he was given IV fluids, paracetamol, ibuprofen, and his fever improved. His heart rates remained stable around 100, and he was still saturating 94% on room air by the end of his A&E visit. His clinical picture was concerning for either COVID-19 or respiratory viral illness, but in the early days of the pandemic, with our limited testing, in the absence of any medical history or risk factors, he was not tested for COVID. He was discharged home with instructions to self-isolate. So let's talk briefly about that outpatient monitoring program that Mark just mentioned. For our patients who tested positive for COVID, either from the clinic or from the A&E, those with reliable phone monitoring were enrolled in a phone-based monitoring program where they were asked 2 questions daily for 14 days after their positive test. These 2 questions were simply, do you feel worsening shortness of breath? And do you have any clinical symptoms that concern you? If they said yes to either of these 2 questions, they screened positive for their survey and were connected with a triage nurse who then could ask a more extensive list of questions. Based on the nurse's clinical concern, they could refer the patients either back to clinic or back to the A&E for further evaluation. So back to Mr. A, 6 days after his initial A&E visit, so now day 8 of his symptoms, he represented with worsening productive cough, nausea, and vomiting. He was still febrile at 38.9 degrees Celsius. His heart rates were in the 100s, blood pressures 120s over 80s, and this time he was saturating 89% on room air. His heart and lung exams grossly still appeared normal. And his labs, including his UEC, were stable. His transaminases were mildly elevated compared to his first A&E visit. He had slightly worsening leukopenia, though still within normal range, and his lymphopenia remained stable. He had new mild thrombocytopenia. His chest x-ray this time, however, showed new patchy bilateral infiltrates. And he was tested for COVID-19 and his PCR came back positive. So let's review some of the laboratory abnormalities that we can see with COVID-19. This is a disease that can affect all of our organ systems, and so we can see a broad array of different laboratory abnormalities. On your UEC, you might see an elevation in your BUN and creatinine. On your FHG, about 33% of patients will have leukopenia. with lymphopenia present in over 80% of patients. About a third of patients will also have thrombocytopenia. Abnormalities in the liver study tests are also very common. And these patients might also have abnormal coagulation markers, such as an elevated D-dimer, and then signs of inflammation, such as an elevated lactated dehydrogenase, elevated CRP, ferritin, and IL-6. We know from studies that an elevated D-dimer in lymphopenia have been associated with non-survivorship or increased mortality. And other elevated inflammatory markers, such as LDH, CRP, and ferritin, lymphopenia, and elevated liver studies have been associated with severe disease. In terms of radiographic findings, we really see the gamut of different presentations. Chest x-rays can be normal or have very mild abnormalities, such as in this picture, or patients can have very fulminant presentations with very impressive bilateral patchy infiltrates. The most common chest x-ray finding are bilateral abnormalities seen in 75% of patients. CT is more sensitive than chest x-ray. And notably, up to 18% of patients might have no radiographic abnormalities, as Mr. A did not have in his first A&E visit. And then conversely, imaging can be abnormal even in asymptomatic patients or patients with very minimal symptoms. Coming back to our spectrum of disease and how that influenced our inpatient management, now Mr. A is presenting with moderate disease. He has signs of lower respiratory tract illness. He's got pneumonia, and the decision was made to admit him to the floor. For patients we admitted to the floor with COVID-19, all patients received serial laboratory monitoring, which included UECs, liver studies, FHDs, inflammatory markers, in cardiac biomarkers, and an ECG every 3 days. We also obtained chest imaging either through lung ultrasound, chest x-ray, and then very rarely we employed CT when it changed management, only to limit our exposure to other staff.
So at this point, the decision is made to admit Mr. A to the hospital. So let's go over a couple of things. Firstly, let's review the isolation precautions that we'll be using, the structure of our COVID-19 wards and our COVID-19 care teams, and then also review some workplace changes that we deployed at our institution. So in terms of infection prevention, some of our practices evolved, of course, over time as our knowledge of disease transmission evolved as well. Initially, of course, we were concerned about droplet transmission of COVID-19 infection spread via fomites, and initially it was actually thought that there was a relatively low incidence of asymptomatic transmission of the disease. So initially, some of our protocols included admitting most patients to droplet and contact or under droplet and contact isolation precautions. Patients were asked to wear a mask when they were in the hospital. We also used a buddy, don, and doff system where we had a trained observer who would actually watch providers and staff members don and doff personal protective equipment. And so that was to ensure that PPE was appropriately used and applied. And then most importantly, during the doffing process, having a trained observer there to watch that process unfold to ensure that there was a minimal risk of either cross or self-contamination. And then we also geographically co-located patients with COVID in one ward or one space within the hospital. And then we did provider cohorting as well, where we would have providers, rather than having mixed services of patients with COVID-19, as well as other conditions, we tried to have single providers or dedicated providers for patients with COVID-19 infection. Also, whenever anyone came into the hospital, but especially for all patients being admitted, we performed universal symptom screening, regardless of sort of the chief concern that the patient presented themselves. Then over time, we of course continued to be worried about droplet transmission of COVID infection. We still worried about fomites, but something we felt that we had under better control in the hospital. And then there was also a growing body of evidence that there was perhaps more asymptomatic transmission than we had initially realized. So with time, we eventually implemented a universal masking with either a procedural or a surgical mask for everyone in the hospital. We deployed universal testing of all patients who were admitted to the hospital, regardless of the indication for admission. And we'll show some pictures of this, but we also created these sort of hot and cold zones within the hospital wards in order to facilitate the delivery of care. So we'll run through the infectious isolation precautions that we used in the hospital quickly. So this is sort of the decision tree that we used. Once the decision was made to admit the patient, the first decision that had to be made was whether or not the patient had symptoms that could be consistent with COVID-19 infection. If the answer to that was no, then the patient would be admitted on sort of our standard precautions, which relies primarily on hand hygiene. The patient did have symptoms that were concerning for COVID-19 infection. The next question and branching point in our algorithm for isolation precautions was whether or not the patient was going to be undergoing any aerosol generating procedures that you see listed here. If the answer to this question was no, patients were placed on droplet and contact precautions in the hospital, meaning that they use some form of eye protection, either a shield or goggles, as well as either a surgical or a procedural mask, in addition to gown and gloves. If the patient was going to undergo an aerosol generating procedure, they were transitioned from droplet contact precautions to contact and airborne precautions with the use of either a PAPR hood or an N95 mask. And pending space availability, we used negative pressure rooms. So this slide, we're going to do an overview of the COVID units and sort of that hot and cold zone that we utilized into the pandemic. So there's sort of a one-way hallway that you see here in this schematic with an entry point and an exit point. And then the patient rooms are these sort of solid blue lines that you see on the top and the right side. And then note that either the entire unit or each individual room was under negative pressure. So as you entered the unit, you would come into a donning station where PPE would be applied. And then as you exited the unit, there would be a doffing station where you would be able to remove your PPE. And again, at each of these stations, we utilize this buddy, don, doff, or trained observer system. And then just to round out this schematic, on the right side and the upper side along the patient room doors, that area sort of in red was the hot or dirty or contaminated zone. And then the inner layer of this hallway was actually the cold zone, clean zone, COVID-free zone, lots of names. But this was a space where you could actually walk through the unit while not wearing PPE. And so this is a photograph of the actual unit on the floor. So this was not in the ICU, but a similar procedure was implemented there. And you can see here, we're sort of standing in that donning station where PPE would be applied, and then providers or staff members would step into that sort of hot area. And this was a huge factor in our efficiency over time, especially as we had more COVID-19 positive patients in the hospital. Having that sort of hot zone allowed you to go from room to room without fully donning and doffing PPE again, but rather just using hand hygiene and the exchange of an overlaying pair of gloves as you went from room to room. And then additionally, on that cold side that you see in blue, other team members, staff members, providers, if it was realized that a medication or equipment was needed while someone was in a patient room, you could call for that and someone could quickly bring that through the cold lane and hand that over the line into the hot zone. That was very helpful. And then additionally, we see here is a photo of actually a workspace in our COVID intensive care unit where there's actually a workstation that's sort of in this hot zone or contaminated zone, where providers or staff members were able to stay in PPE for more prolonged periods of time, but also had access to workstations in the contaminated zone where they could accomplish tasks and advance patient care.
So coming back to Mr. A's hospital course, just to remind us, he's a 23-year-old man with no past medical history admitted with COVID-19 pneumonia. His symptoms started 7 to 8 days prior to admission. He was initially placed on 2 liters nasal cannula and was started on hydroxychloroquine, as was our practice in the early days of the pandemic, where we used it liberally. His laboratory studies are listed here below. His UEC, liver studies, FHG were all stable. Lymphocyte count was stable. He had elevated inflammatory markers, including fibrinogen, IL-6, LDH, ferritin. He had elevated coagulation markers, D-dimer and PT, but his cardiac biomarkers were normal. And so to round out our management of patients with moderate disease, we had serial laboratory studies. We included chest imaging when it would change management. We would also try to minimize the amount of IV fluids these patients would get. And knowing that these patients were at increased risk of clotting complications, all patients had VTE prophylaxis instituted unless there was a clear contraindication. In the early days, we put every patient on telemetry, but ultimately found that this was not a good way to use our resources, nor did we capture very many abnormal events in routine telemetry monitoring. And so we limited our use of telemetry monitoring to those who had severe disease in the ICU, or those patients who had abnormal cardiac markers and ECGs on admission. As I mentioned, in the early days of the pandemic, we liberally used hydroxychloroquine in patients with moderate disease, but that has now largely fallen out of favor. So continuing on his hospital course, on hospital day 2, his respiratory status worsens. His oxygen needs increased to 4 liters nasal cannula, and his respiratory rate is in the 40s. He is intubated and transferred to the ICU. And so now we see Mr. A moving from moderate to severe disease. In our management of severe disease, early on, we were employing early intubation for these patients, but now have moved away from that for a trial of high flow nasal cannula or non-invasive positive pressure ventilation, such as CPAP or bilevel, prior to proceeding to mechanical ventilation in our patients. We've also instituted awake proning, as well as proning of our patients who are critically ill and intubated. Some of the medications that we use in our patients with severe disease include tocilizumab, which is an anti-IL-6 antibody, which we employed for patients with elevated inflammatory markers, most notably elevated IL-6. Newly, we've started using dexamethasone based on some new studies that have shown its effectiveness in severe and critical disease. And then we quickly saw Mr. A move from moderate to severe to critical disease. And for our patients who are critically ill, we used remdesivir. One thing to note is that some patients with COVID-19 have a rapid decompensation with a quick transition from moderate to critical disease, typically around days 7 to 10. This was a pattern that we saw over and over again. Let's briefly review some of the complications that we can see with COVID-19. We know that about 5% of all patients with COVID-19 will require ICU level care. Of all comers with COVID-19, about 41% of patients will require some form of oxygen support during some portion of their illness. In patients hospitalized with severe disease, up to 90% of those patients will require oxygen support. ARDS, about 3% among all patients, but close to a third of patients who were hospitalized with severe disease. Ventilatory support, about 7%. Looking at some of the other organs affected, the rate of renal failure requiring renal replacement therapy was less than 1% and about 5% in hospitalized patients. Coagulopathy, less than 1% overall. From early studies from China, though there are some thoughts that this number is actually much higher, and about 20% in patients who are hospitalized with severe disease. Cardiac complications such as shock, arrhythmias, and heart failure, again, are not very common when we look at all comers with COVID-19, but affect up to a fifth of patients with severe disease that are hospitalized. One of the important things to note is that cardiac complications are common in those with severe disease, even in the absence of underlying cardiac abnormalities. To round out Mr. A's ICU course, he was initially started on hydroxychloroquine, but then once he transferred to the ICU, he was enrolled in a remdesivir trial and either received remdesivir or placebo. Unfortunately, he continued to progress and developed ARDS and worsening shock. He was started on paralytics. Because of uptrending inflammatory markers, he received one single dose of tocilizumab. His respiratory failure continued to progress and was started on epoprostenol. And then in his final hours, he developed refractory cardiogenic shock despite multiple pressors and dobutamine. And on day 14 of his symptoms, he unfortunately passed away. To sort of solidify many of the things that we've already talked about, this is a proposed staging system for COVID-19. In the early stages of infection, this is when you see high viral replication. And this is when patients present with an acute viral syndrome. They're febrile, they have cough, they might have GI symptoms, myalgias. In stage 2, which typically occurs around week 2, that's when patients develop the pulmonary symptoms of COVID-19. They become hypoxic, develop shortness of breath. They can have abnormal chest imaging at this point. You're starting to see some host inflammatory response, but really it's in stage 3 where you see this hyperinflammation stage. And it's this hyperinflammation, this cytokine storm, that actually results in many of the complications, the end organ damage that we see in COVID-19. And so here this results in ARDS, shock, cardiac failure, and you see inflammatory markers and cardiac biomarkers elevated in this phase. The authors of this paper propose that we should be targeting our treatment depending on the phase of infection. So antiviral therapies, such as remdesivir, chloroquine, hydroxychloroquine, and convalescent plasma should be most utilized in the early stages of infection, though could be used throughout any stage. While there's a robust viral response or viral replication in the early stages, we should seek to decrease the level of immunosuppression. But in this hyperinflammation stage, this is where we see the benefit of anti-inflammatory medications such as corticosteroids and tocilizumab. So our take-home points: most patients with COVID-19 will have mild disease and not require hospitalization. In patients with severe disease, COVID-19 can cause multi-organ failure. In the triage of COVID-19 patients, you should take into consideration a patient's ability to self-isolate and their risk factors for progression to severe disease. These risk factors might include laboratory and radiographic features that are helpful in risk stratification, but in isolation, they themselves do not determine disposition. Workplace modifications, such as the creation of COVID units in hot and cold zones, can facilitate more efficient delivery of care. And patients with COVID-19 can have a rapid decompensation and progress from moderate to severe or even critical illness around days 7 to 10. And the most important is that our best practices are frequently changing as we learn more about this disease. And it's important to be able to adapt and revisit our strategies as new information comes out. So we'll go ahead and open up the floor to questions. I just want to say a big thank you to a number of physicians who helped us in the creation of this talk. As we mentioned, Dr. Nick Johnson and Dr. Janelle Stewart will be joining us for the panel discussion. Dr. Nick Johnson is an emergency and ICU trained doctor who's been involved in some COVID-19 studies. And then Dr. Janelle Stewart is an infectious disease trained expert who has experience working in Kenya and has also been involved in some clinical trials. She has to leave at 10, and so if we have any specific questions that are more ID specific, infectious disease specific, I would encourage us to ask those at the beginning of our panel discussion.
Thank you very much for the excellent presentation. That has been really, really excellent in terms of the movement of your patients from the ICU from the outpatient all the way to the ICU. I think one of the questions that I have, and even as right now healthcare workers are mourning the death of one of the healthcare workers, with this model, my question would be, so how many of your healthcare workers have actually been confirmed to have COVID-19, and is it because of community, or is it as a result of working with COVID-19 patients?
Sure. So we actually have a little bit of data for that's been collected. So our employee positivity rate so far, as of maybe a week or two ago, in terms of COVID PCR positivity is about 4.7% with over 5,000 tests performed. And we actually have been rolling out a serosurvey program at the University of Washington. And in terms of serologic positivity, with over 3,000 tests performed, our seropositivity rate is just over 3% at 3.1%. I think, of course, it's very hard to know whether or not those positive tests are coming from either community exposures or exposures in the hospital. But it's worth noting that I think both of those numbers are lower than the numbers in the community. So I think that's suggestive that our infectious isolation precautions and some of these changes that we've mentioned are effective in terms of preventing healthcare worker infections.
Thank you very much. I'll take the question from Rumesa and Kiende, and they're asking, have you had any experience with hyperglycemia and COVID? So right now we are seeing in our asymptomatic and our moderate patients, like a picture of a new onset diabetes mellitus. Is it the picture that you're also seeing there, or is it something that's unique to us? And then in how, your management, how then do you go about managing that?
Yeah, I can speak to our experience on the floor, and then maybe Dr. Johnson can also speak to his experience in the ICU. We certainly have seen some hyperglycemia in patients who present with acute infection, but we haven't seen an overwhelming group of patients coming in with new onset diabetes as a result of COVID-19.
I agree with that. I think we've seen a fair amount of hyperglycemia in the critically ill patients, but I don't think it's disproportionate to other critically ill patients who have this high inflammatory response. I think more likely what we're seeing in the ICU is just hyperglycemia related to a severe stress or inflammatory response and not new onset diabetes, but that's really interesting.
Thank you very much. So a question from George Owiti. What experiences have you had with gravid patients in the ER, and whether the gravid patients who don't have any comorbidities and they're gravid patients with some sort of comorbidities? So have you had an experience managing such patients? And what is your experience?
So I think for Yelena and I, as adult internal medicine doctors, we actually really are kind of spared from the obstetrics side of COVID care. I know we have had some gravid patients admitted to the hospital, but maybe some of those patients have either been in the ED or the ICU. And Dr. Johnson can attest to that a little bit, or Janelle Stewart a little.
Yeah, I actually work at Harborview Medical Center, which is one of our other hospitals where we don't take care of a large volume of gravid patients. So I've not had a lot of experience in caring for patients with COVID-19 who are gravid. I do know that we have had some patients who have been cared for in our intensive care unit at the university hospital who have been pregnant and have had fairly complicated courses as well. So our experience is relatively small, fortunately, and limited. And I don't know that we can differentiate based on the small numbers whether there's a higher risk for patients with comorbidities or not, but I would imagine that there is a higher risk for patients who are both gravid and have underlying medical comorbidities.
Okay. There's a question from Edna Oje in terms of experience with point of care ultrasound. So have you done any for your COVID-19 patients, and what's the experience with the point of care ultrasound versus the chest radiograph?
Yeah, and I can answer that. So we have rolled out a program at our facility for the use of point of care ultrasound in evaluating and following patients who have COVID-19 pneumonia. We actually were able to procure funding for a dedicated ultrasound for our COVID units. And so that was a quote unquote dirty ultrasound that just stayed with our COVID-19 patients. One of our, Mark and my colleagues, who's an ultrasound champion, also created a system where we would have a radiologist review our images so that we would have some professional input on the images that we obtained. And so in order to minimize staff exposure, we tried to minimize the number of studies that these patients obtained. And so that really called us to fall back on ultrasound. And so we were performing things like lung ultrasound, cardiac ultrasound. Lung ultrasound, it's relatively easy to perform and you can get relatively reliable images. And so I would say that that was the most broadly used among our staff. And some of the findings that we would look for are B lines, which correspond to alveolar filling processes like you might see in pneumonia. And so we would often follow B lines on these patients. And this allowed different providers to see the same patient, and you can compare ultrasounds and to see how a patient was evolving.
Thank you very much for your responses. I'll take the question from Jamila. And so the question is, what is your survival rate of the intubated patient? And maybe like to ask, right now there's the move towards high flow nasal oxygen and use of CPAP. So which criteria do you use so that you move from a patient who's in outpatient, then they get respiratory distress? How do you start, what do you start with and progress up until intubating the patient?
Yeah, I can take this one. I've looked at our data fairly recently, can comment on survival, but I'll answer your question first about kind of the typical progression. Often when I meet these patients as an intensive care doctor, they're already either in the hospital or in the emergency department and requiring a fair amount of respiratory support. We've heard a lot about this silent hypoxemia or happy hypoxemia, where patients are disproportionately hypoxemic compared to their level of respiratory distress. Those are the types of patients where we're more aggressively trying non-invasive support first, high flow nasal cannula or non-invasive positive pressure ventilation, when they have a lot of hypoxemia but not profound respiratory distress, no hypercarbia, no acidemia, no other organ dysfunction. And we find that in those patients, we're often able to support them with less invasive measures for a period of time. Some of those patients will go on to recover and will never require intubation and invasive mechanical ventilation, whereas others will progress and worsen and will eventually require intubation and invasive mechanical ventilation. The key is close monitoring, because some of these patients do deteriorate quite rapidly. Our mortality rate for patients who are intubated and receive mechanical ventilation has actually changed over the course of the disease over about 4 months. Our early patient population was mainly elderly and comorbid, and came from a lot of nursing homes and assisted living facilities. And so our mortality early in the disease was quite high, in the 50 to 60% range. In the later part of the disease, where we've started to see younger people without significant comorbidities in the face of community spread, our mortality looks very similar to other patients with acute hypoxemic respiratory failure in the 20 to 30% range. And that's been true in other similar centers across the US as well. Early mortality was quite high, and then as we've gained experience and our patient population has changed, mortality has gotten lower to ranges that are similar for other patients with acute hypoxemic respiratory failure.
Thank you very much. So I'll take a question from Eunice Kihara. So have you noted any chronic post-COVID complications in patients who recovered from COVID-19? So once they've been declared recovered, do they come back? And if they come back, do they have any further complications that can be attributed to COVID-19?
So I think this is going to be an area where there is a lot of evolving data. Obviously, at the beginning of the pandemic, we don't really know because we haven't really gotten there yet. But I feel like probably the thing that we have seen most, especially in some of our patients who've had quite prolonged hospitalizations, and I would love to hear Dr. Johnson's thoughts on this, but like post-ARDS fibrosis in patients who get quite severe lung disease, we've definitely had some patients who have quite prolonged weaning from supplemental oxygen, and who on imaging down the line after they've been cleared from their infection and they're able to go back to the scanner have significant amounts of fibrosis. I think that's been one of the biggest post-COVID complications that really comes to mind.
Yeah, I agree. I think the other thing we're seeing in the short to intermediate term is we only have a few months of caring for patients with this disease is profound weakness that we think is likely a severe critical illness, polyneuropathy or myopathy. There are many patients who have very prolonged episodes of mechanical ventilation, receive a lot of sedating medications, neuromuscular blockade, and develop really profound muscular weakness and take a long time to come off the ventilator, and then the recovery after that is likely going to take on the order of months to years. So that's another complication that I think we're all really concerned about. The long-term pulmonary consequences of this disease are still not really known. There are certainly reports of fibrosis after ARDS in both COVID and non-COVID viral respiratory illness. The majority of patients with ARDS who receive mechanical ventilation do recover most of their lung function by the 1-year mark, but there are certainly exceptions to that. And I think we just don't know because we haven't had long enough to follow these patients.
Yeah, thank you very much for that. I'll take a question from Oguido. So which simple tools do you use for predicting deterioration? Because we've talked about from the stable patient all up to the ICU. So for us in like a resource constrained setting, which simple tools can you give us or tell us about that we can use to predict deterioration in our patients?
Yeah, so I think the respiratory rate is a very helpful thing to be able to follow. As Dr. Zhang alluded to earlier, we very frequently saw these patients, we kind of used the term like fell off of a cliff basically, but had this really expedited deterioration at some point, even over the course of a couple of hours, where they would go from that sort of moderate illness category to severe or even critical illness quite quickly. And I feel like the first sort of harbinger of that was often an increased respiratory rate, sort of overt respiratory distress, increased work of breathing, accessory muscle use, those sorts of things. I feel like, I feel comfortable saying, I think that the most common reason that patients ended up going to the ICU in the setting of COVID infection was for respiratory issues. And I feel like, yeah, respiratory rate and work of breathing were oftentimes reasons to make those transitions for patients, in addition, of course, to needing higher levels of oxygen support.
Yeah, I would agree with that statement. Though we talked about some of the fancy and like more esoteric labs that tended to correlate with more severe disease, none of them predicted this decompensation, like just watching the patient, seeing what their respiratory rate was, seeing what their oxygenation was. We would often concurrently see an escalation in their oxygen needs with a worsening of their respiratory status or their work of breathing. And so at our hospital, we have something called a rapid response team, which is made up of a group of ICU nurses who are able to keep closer tabs on patients who are at risk for decompensation. And so that's something that we used to help more closely monitor these patients when they were on the floor, but we're starting to have escalating oxygen requirements. And then early involvement of the ICU team, just to let them know, maybe come assess the patient before there's rapid decompensation.
Thank you very much. So a question that I usually hear even from our IDUs is in terms of when to discharge the probably moderate and mild patients. So they test positive for COVID-19. Should we wait all up until they test? We have 2 negative tests, or what's your practice in Seattle?
So our practice for discharging patients to communal living facilities like rehab facilities, skilled nursing facilities, did require patients to test negative twice before sending them back. But what we found is that people can have viral shedding for many, many weeks, sometimes up to 8 weeks after their initial illness, and even after many weeks after their symptom resolution. And so we did not require people to test negative prior to sending them home if they had stable housing and had the ability to self-isolate. And then Janelle, maybe you can jump in and speak to if there's any changing feelings about this. But our National Center for Disease Control guidelines are that once patients are asymptomatic, either after 10 days of disease or after they're asymptomatic for 72 hours, they are able to come out of isolation. And so we think that the positive PCRs that we're getting from the nasal swabs do not necessarily represent enough viral shedding that it can be infectious.
I can add to that by commenting that there are very few studies that actually look at how healthy the virus is and if it is able to infect other people. And because those studies are technically difficult and expensive to do. But the few that have been done suggest that those prolonged viral shedding are really not viable virus that can infect other people. So probably PCR detection of dead virus. That being said, people who have continued symptoms, fevers, respiratory symptoms, could have prolonged viral shedding that could infect other people. So I think a system that relies on symptom-based screening, I think, is effective.
Yeah, and I'll add, in terms of discharging patients from the hospital, we've alluded to this sort of 7 to 10 days from illness onset, this window where patients can decompensate. And this is often something where patients would be admitted on day 5 or 6 to the hospital, and they were sort of borderline in terms of their clinical appropriateness for discharge. And we often would make a decision to keep them in the hospital for close monitoring sort of through that window, where in the natural history of the disease, we might already anticipate decompensation because we are worried that something could happen in that window, especially if a patient is going to be leaving the hospital and going to a place where they're more remote or have less readily accessible health care.
Thank you very much. There's a question here on the role of antibiotics. Is there a role of antibiotics in the management of COVID-19?
I'm happy to answer this one. This is Dr. Janelle Stewart. I would say that there's still some debate, although it is very much closing down as no, regarding azithromycin because of the possible anti-inflammatory properties. So I know that there are still some ongoing trials evaluating the use of azithromycin in combination with other treatments. But in general, no, there is not a role for antibiotics in the treatment of this viral infection. And then Nick, I don't know if you want to comment on your experiences with co-infections in the ICU. I'm not concerned about co-infections in the outpatient setting, but once you have people on ventilators, that's a different story.
Yeah, I think it's a challenging decision later on in the ICU when patients are sort of in this inflammatory phase 7 to 14 days into their illness and getting sick or otherwise to completely exclude a superimposed bacterial infection. We also had been limiting the numbers and types of diagnostic studies that we're doing for patients to limit exposure to other healthcare workers. And so our usual tools, things like bronchoscopy and high quality chest imaging, are fairly limited. So we often did use antibiotics later when patients had a second worsening in the ICU and weren't able to exclude a superimposed ventilator-associated pneumonia. And we did find a fair number of positive cultures, both from the blood and the respiratory tract in patients who were further along in their disease. And that isn't unexpected for patients who are receiving, for us, a median of about 10 days of mechanical ventilation, with some patients receiving 2 or 3 weeks on the ventilation. So I would say later we definitely are using antibacterial agents, but it's likely to treat ventilator-associated pneumonia and other complications of prolonged critical illness.
Thank you very much. I'll take a question from Judy Mashuka, and she's asking whether you can kindly repeat the components of the outpatient monitoring program that is recommended for the low-risk patients, so that maybe she wants to adopt it. So what are the components of the outpatient monitoring program?
I can take this one. So I can go back to that slide just so that we're looking at it again. And it relied heavily on our nurses. And so for patients who were COVID positive and had a reliable phone, we were enrolling these patients in a phone-based monitoring program, which included 2 questions that they asked these patients every day for 14 days. And those 2 questions were, 1, are you having any worsening shortness of breath? And 2, are you having any symptoms that concern you? So very simple. And if they answered yes to either of those 2 questions, that would trigger a call to a triage nurse who then could ask a more extensive list of questions and figure out what exactly were symptoms that this patient was concerned about. And then depending on the triage nurse's level of concern, she could either send this patient back to clinic where they could be further evaluated, or if they sounded more ill, she could send them to the A&E to be evaluated.
Thank you very much for that. I'll ask a question that's been asked by several individuals in terms of the reinfection rate. There's the news or the rumors that are going around that there'll be a second wave, and that COVID now it's something that's here to stay. So are you seeing reinfection among your patients, and what rate of reinfection are you seeing?
I can try to answer this one. This is a challenging topic because there's still a lot of ongoing research to understand this. I don't believe that we've seen any true reinfection at the University of Washington. And the case reports that I've seen in the news, I'm very skeptical of that they are true reinfections. I think because of that issue that we commented on earlier with the PCR positivity in the nose for weeks, you might see the virus being detected in the nose, but that doesn't necessarily represent a reinfection. I think that our experience from other coronaviruses, we know that antibodies are produced, and I would not expect a new infection immediately after, but we don't yet know how long those antibodies will last. I suspect that they will last months to years, but we can't tell individual patients how long they're protected for. So stay tuned for more research to definitively answer this question.
Thank you very much. I'll take a question from Robert Kipkoech. So is there a relationship between COVID-19 and blood group? I know in our papers a few days ago, it was published that if your blood group is A, you have higher risk of getting COVID-19 and probably a severe, like B, the severe form. So is there a relationship between COVID and blood group?
I can try to answer this one first, and I'll be curious to hear if any of the other presenters have differing opinions or thoughts on this. But there have been some interesting studies, mostly out of China, that looked at large groups of patients and a correlation between specific blood types. But it doesn't infer 100% protection for one blood type. So I don't want to put too much emphasis on these studies because I don't think it should change anyone's behavior. And I don't think that it's going to be accurate enough to help with triaging our patients. So that is my takeaway. There might be some worse outcomes in some groups or slightly better in other groups, but I don't think that it's a strong enough correlation that it would change our medical practice or individual behavior of those patients. I don't know if anyone else has other comments on that.
Thank you very much for that. I'll take a question from Samira Osman. So what is your experience in treating COVID-19 patients who are also asthmatic? Because especially right now in Kenya, it's the season where it's a bit cold and we get more of the patients who come in as asthmatic. So what do we do for such patients, even in the categories of mild, moderate, severe, and critical?
Yeah, so I think there have been a couple of interesting logistical challenges that have come up when admitting patients who have an underlying diagnosis of asthma with COVID-19 infection. So the first being, of course, that nebulizer treatments are aerosol generating procedures and would require sort of a higher level of infectious isolation precautions. So there was actually a move at our institution, and I think across our health system at large, to sort of try and avoid using nebulizer treatments. Of course, if they're necessary and we'll do them. But oftentimes I think that did sort of change our threshold to give nebs, and that we often would admit patients with either COPD or asthma and give them like a metered dose inhaler, and then, you know, try some of the other standard therapies that we would do for either COPD or asthma. But I think that's sort of an interesting logistical challenge that arose from that. But otherwise, I think, you know, at least steroids are coming back. So maybe that's something that would be helpful, of course. And someone brought this question up in the chat, whether or not steroids should be used on the earlier side or the later side. And I think, of course, coming back to that article from the JHLT out of the Brigham with those phases of infection, was sort of the first viral replicatory phase where patients are ill and then transitioning into that hyperinflammatory stage of disease. I think the thinking, and of course I'm open to ideas or comments from the other speakers, but you know, there may be a sweet spot where introducing steroids is appropriate and that some degree of viral suppression and adaptive immune response is already happening, and waiting for that sort of inflection point in the disease before you start steroids, which would also confer some benefit for asthmatics. But I think it's just one of those risk benefit assessments that you have to make if you're earlier on in the disease course, where, you know, the risk benefit of some additional immunosuppression during this sort of viral response phase and whether or not you're comfortable doing that. But otherwise, often these lower respiratory tract symptoms in the pulmonary phase happens at that sort of inflection point in the disease. All I can say is maybe fingers crossed that sort of the flare of asthma coincides with this transition point, and the addition of steroid therapy may be helpful, both from an asthma perspective as well as for an hyperinflammatory perspective.
Yeah, I'll add a couple of things, especially about the more severe end of the disease spectrum. For mild to moderate disease, I completely agree. One of the nice things is that it seems like the therapies that might be helpful in COVID-19 overlap heavily with a lot of the therapies that are probably helpful in an acute asthma exacerbation, especially in the moderate range. I think on the more severe end, it's the treatments align even more closely. We're using non-invasive ventilation for respiratory support as a preferred modality in patients with obstructive lung disease. For us and patients who are on non-invasive ventilation, we're generally treating them in airborne precautions in a negative pressure room, where we can also administer nebulizers and other asthma-specific treatments. And then the steroid question is an interesting one. The recovery trial has only been published in preprint form, so we haven't seen a final peer-reviewed version of the study, but it does look like in one of their pre-planned subgroup analyses, the largest benefit was seen in patients who had at least 7 days of symptoms, and also in who had at least moderate disease, so at least had hypoxemia or invasive mechanical ventilation, but no benefit was seen, and potentially a signal of harm was seen in patients with less severe disease. So I think for COVID alone, we're restricting our use of dexamethasone to patients who are further along in their disease course and have more severe disease. But if there's another indication for corticosteroids, like an acute exacerbation of asthma or other obstructive lung disease, we treat those patients as we normally would with steroids early on in the disease course.
Thank you very much for that response. I think the other question I've seen a couple of the presenters or the attendees asking is how are you dealing with healthcare worker fatigue, and how do you motivate them, especially now that they are in the front line and they're putting their lives at risk even as they serve patients? So what modalities do you usually use?
One thing that was really helpful from our hospital administration was essentially weekly check-ins during the height of the pandemic here in Seattle. And so every week we would have a presentation on COVID-19 to be essentially up to date with any new literature that came out. And then some of those sessions were also dedicated to just general wellness. It gave us a platform to voice any concerns that we had that were subsequently instituted as policy changes. It gave us a place to debrief about really challenging patients who we cared for, or those that really affected us deeply. And so I think creating a space for your workers to be able to voice any concerns and to just talk about the challenging patients that they've cared for has been really cathartic for us.
Yeah, I will echo that, and I tried to chime in with an answer in the chat too about this question, because I think it's very important. There are a lot of challenges, some that are anticipated and some not so much when it comes to taking care of these patients. And of course, we're all dealing with the effects of the pandemic outside of the hospital and in our personal lives. And so I think, as Yelin mentioned, just having the space, the open space or forum to just acknowledge that people are feeling that way and to be able to talk about some of these issues, I think has been hugely helpful, and just acknowledgement can go a long way. And we also have a lot of resources available for staff, like individual counseling or an opportunity to talk with another provider in a safe and confidential way if you feel like you need a little bit of extra time to sort of discuss and process things with another person.
Thank you very much. There was a question from one of the attendees. During the discussion, we said that the renal complications are about 1%. So the question was, how do you deal with the renal complications when they happen in the midst of COVID-19? So what process do you go through?
I can take this one. So in the intensive care setting, we are seeing a large number of patients have what we think is an acute virally mediated acute kidney injury and also an acute hepatitis. Those are the two most common extrapulmonary organ dysfunctions that we see. Usually the acute kidney injury is an ischemic or septic acute tubular necrosis, and it's fairly mild and fairly self-limited and improves with supportive care. There are certainly a subset of patients who develop more severe acute kidney injury, develop oliguria, acid-base abnormalities, and go on to require renal replacement therapy. And in those patients, we use our typical indications for renal replacement therapy and will often use continuous renal replacement therapy in the ICU setting because these patients are often unstable from other perspectives as well and may require volume removal and other things that we can do with continuous renal replacement therapy. So our management is quite similar to other similar types of patients.
Thank you very much. There's a question from Dr. Peter and Martin. Is there any role of supplements, especially for the mild patients who probably have not so severe symptoms or maybe are asymptomatic but COVID positive? Is there any role of vitamin C or vitamin D or zinc supplements among these patients? And is it something that you routinely do?
So I can speak to our experience in that we have not been routinely recommending them for our inpatients or outpatients. I do know that there was some evidence talking about the association of vitamin D deficiency with more severe disease. But I think I'm not as familiar with the data. I don't know if any of the other panelists have any opinions on this, but I think the data for any supplements is pretty limited at this point, and we have not been routinely recommending them for any of our patients.
Yeah, I agree with that. I've been previously involved in some work around vitamin D and critical illness, and this was before COVID-19. And I think what we found was that there's a clear association between vitamin D deficiency and development and worsening of critical illness. But I worry that this is collinear with a lot of other factors, that patients who are vitamin D deficient are more likely to also have other nutritional deficiencies and perhaps other medical comorbidities that could make their disease more severe. When we looked at this question before COVID-19 and did a large randomized trial in the US of vitamin D supplementation for patients with acute respiratory failure or shock, we found that actually supplementing vitamin D in critically ill patients who were deficient did not improve their outcome. And I suspect a similar story would be true for COVID-19. I think that a lot of these vitamin deficiencies just tend to run with other things that put people at higher risk for critical illness.
We're almost coming to the end of the session, and for people who've raised their hands, please feel free to unmute yourself and ask. I'll take a question from Moses Mwenda. So have you used plasma therapy, and what's the success rate of plasma therapy?
So we have a slide on this, if Mark, if you want to pull that up. And then Nick, maybe you can chime in with your experience with this as well. As of right now, there's very limited data for the use of convalescent plasma to treat COVID-19. The theory behind this is obviously if you take blood from a recovered COVID-19 patient. That's going to contain antibodies that we can then infuse into a patient with active infection. But again, very limited evidence. There's some suggestion that it may reduce mortality in critically ill patients, but the vast majority of these studies have like less than 10 patients, and they're not randomized. Can you advance the slide? So this was a recent systematic review that came out in June, I believe, that included 5 studies, a total of 27 patients. So we're really talking very few. That essentially concluded that there's too limited evidence for us to inform our use at this time. This is an active live systematic review at the Cochrane database that's continually being updated as new data comes out. And at this point, they similarly conclude there's no clear evidence for use. And this was a very new paper that came out within the last month that is a randomized control trial on the effect of convalescent plasma therapy. And they found that there was no decrease in time to clinical improvement in patients with severe or life-threatening COVID-19. This included 103 patients. And it was actually terminated early because there was no clear benefit. So overall, I would say that these are still very small numbers, and more studies need to be done before we can make a firm conclusion on its effectiveness.
I completely agree. This was in our armamentarium of early therapies that we were using without much evidence. And obviously in those situations, it's really hard to judge success. It's still something that we will use in patients on the most severe end of the disease spectrum, but there's really no high quality evidence that this is an effective therapy. I think at the very least, there's some evidence showing it may be safe, but there are multiple randomized trials ongoing at various phases of the disease, including in relatively stable patients early on in the disease, of both convalescent plasma, and now we've started to move on to looking at specific monoclonal antibodies that might bind virus, and we're doing some randomized trials that are just starting in the US looking at monoclonal antibodies as well.
Thank you very much for your presentation. I think it's been a really eye-opening presentation. Even as we're coming to the end of this session, I'd like to give our panelists, kindly give us your parting shots in terms of the management of COVID-19 patients from the outpatient to the ICU. What would you advise us? Like, finally, what are your parting shots?
Sure. So, and thank you for giving us the opportunity to try and pay some of these experiences forward and to talk about a lot of the things that we've navigated in the earlier part of the pandemic here. Really, thank you for the opportunity. And so, parting words, I think, for the outpatient setting, I think by and large, a lot of the decision making that goes on in terms of whether or not to bring someone into the hospital is not that dissimilar to patients with other viral syndromes. I think, we mentioned a lot of additional laboratory evaluation that can happen, but really, while that might inform some of the more nuanced pieces of the decision to admit, really it's a clinical decision that I think we're all ready to make if it needs to be made without that information. And then in terms of sending people out, the most important thing I think is being able to self-isolate safely, and then just patient education around the possibility that they could get worse, especially in the second phase or second week of illness, that they just need to be looking out for things like worsening cough, shortness of breath, chest pain, and that if any of those things happen, that they really should seek additional medical care. I think that's sort of the outpatient piece. And then, Elin, if you're still here, I'll let you chime in about the inpatient piece.
No, I absolutely echo that. I think, we talked there's been a lot of data that's come out about all these specific laboratory studies and all these complications, but honestly, we mostly just used our clinical judgment and knowing how the disease progresses and knowing when to have a heightened concern so that you can more closely monitor a patient while they're on the inpatient setting is probably the tool that we use the most over any laboratory study, over any imaging modality.
And I can echo sort of the back to the basics approach in the ICU. I think we've all been hopeful that one of these new therapies or new tests would produce a miracle cure or really help us in a dramatic way. But really what we've learned over the past 3 to 4 months is that the fundamentals of ICU care are the things that will bring patients through. And if we just stick to the fundamentals, the basic principles of managing the individual patient's physiology and applying the evidence that we've been using in intensive care for many years, that patients can do well and make it through this disease. And really all of these new therapies that are being studied at the very best will give us small marginal gains and improvement in mortality on the order of a couple %. But it's really the high quality supportive intensive care that we've been providing for a long time that's the key in caring for these patients in intensive care.
Thank you very much to all of us, to our presenters, Nick Johnson, Janelle Stewart, Mark Mayo, and Yilin Zan for your lovely presentation. We've really learned a lot. Thank you also for all the people who've attended the session. It's really late. It's late here in Kenya, so thank you for sparing some moments to actually listen to this presentation. And thank you also to Dr. John Kinuthia for hosting these webinars. To all of us, for all the CPD queries, kindly email us at knhcpd@gmail.com and we shall address them. Thank you very much. Good night to everyone who's in Kenya and good morning to the team in Seattle. Have a lovely night or day, depending on your residence. Thank you.
Thank you. Be well.